So let's say that number of visits is like, for this diagnosis set and HIPS code set, whatever, is like 7. So if you get 6 or less, that means you're getting a LUPA payment. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about LUPA and Outlier Payments. But first, if you like our content, please like, share, and subscribe. So what is a LUPA and what is an outlier payment? Well, LUPAs, spelled L-U-P-A, and outlier payments are both payments that are outside of the norm of the regular claim amount. So typically, to understand this, you need to understand generally, like just light understanding of how Medicare home health claims are created and generated and paid out on. So home health claims are generated based off of the initial and recertification OASISs. OASISs are those like 100-page, 100 million question, multiple choice documents, the comprehensive assessments that are filled out at various like major milestone time points, like the start and end of episodes and things like that. Like if somebody goes and comes back from the hospital, just those major evaluation milestones. When a patient is admitted to home health, clinicians fill out an SOC or start of care OASIS. Then at every recertification, a recertification OASIS is completed. Based on this OASIS, your EMR, that's electronic medical record software, is going to make a claim amount. This claim amount is based on your HIPS code. I know it's a lot of like acronyms, but anyways, so it's based on your HIPS code. A HIPS code is generated based off of just the various ways you answer the questions on the OASISs. Without getting too technical, it's like a 5 or 6 character like code that's like numbers and letters and things like that. And each one of those number letters represent a different kind of scoring system on the OASIS. So there's like a functional score, like how functional is your patient. There's, like just various kind of like things that are scored based off your OASIS questions, and it comes out to a HIPS code. The other element of claim generation is going to be your diagnosis set. And so this HIPS code plus diagnosis set is going to determine the claim payment. Now, these HIPS codes, diagnosis sets, the determined claim payments, Medicare assumes based on just like decades of historical information that if the patient scores like this on the OASIS, that we will have a visit range of, let's say, like 6 to 40 visits. And so your claim payment that you end up getting is for 6, let's say for, in the case of this example, to 40 visits. A million years ago when I started in home health, these numbers were set. So like you had to hit 5 visits to get the full payment, or you had to be under, let's say, 35 visits to maintain the claim amount. Anything over 35 visits, you got the outlier payment. So now the payment system has changed drastically over like the past like 10 years, let's say. And LUPAs and outliers are a lot more like flexible based on these HIPS codes and kind of diagnosis sets. So Medicare just has like better statistical information, and they can assume, right? Like, and you're getting significantly different payment amounts for these like various claim patients. So they can assume, let's say, for example, just giving really raw examples, that like, oh, patient with nothing but nursing and like generally just like teachings, non-direct care, things like that, is going to have probably like 10 to 15 visits. So we're going to pay them like, let's say, 2,000 to 3,000 for the episode. Whereas a patient with like therapy, and like, maybe like a diabetic patient is going to have like over 35 visits. So we'll like pay, or like, towards the higher end of that. So we'll pay them like 6,000 for the episode. Things like that. So now the claim payments always varied by HIPS code and diagnosis set and therapy utilization, things like that, or projected therapy utilization. But now they're much more kind of like precisely and in detailed calculated. And now also the LUPA and outlier amounts and thresholds are different. So this leads us to, what is a LUPA? What is an outlier payment? So LUPA, spelled LUPA, is essentially the minimum number of visits you need to hit to get the full episode payment. So a LUPA means you haven't gotten to that number of visits. So let's say that number of visits is like, for this diagnosis set and HIPS code set, whatever, is like 7. So if you get 6 or less, that means you're getting a LUPA payment. And the LUPA acronym means low utilization payment something. So it's a low utilization payment. Utilization literally means like, how many visits are you going to do? And so if you don't meet the minimum number of visits that you need to hit for receiving the full payment for the episode, you are essentially getting a LUPA. The minimum number of visits needed per episode is going to greatly differ on patient, patient like condition. Before, it was you had to hit 5, or there was like some standard number. Now it's just really variable. For some diagnosis, it's like 3. For some diagnosis, it's 7. So it's gonna vary, but it's gonna vary in this like lower episode range. Sorry, in this lower visit range. You're not gonna have to hit 15 visits to get the full payment. It's like, between like 3 and 6, 7, like that. The other end of this is going to be your outlier payment. So the outlier payment means that you have exceeded the maximum number of visits for this episode that is within the visit range to receive full payment. If you exceed that number, you now get paid essentially additionally per visit of excess of, whatever that threshold is. Before, that number was about 35. Now it varies based on condition. When do outlier payments apply, and what are some special circumstances around outlier payments? So I started in home health in 2002, and back then there were no kind of like restrictions on outlier payments. And so what a lot of agencies would do, there were a lot of agencies that would focus strictly on diabetic patients. Because diabetic patients got paid a lot more, because you often would get like, 2 visits a day or 1 visit a day. This would exceed your outlier minimum threshold, and then you would essentially get paid a lot more. So there are some special circumstances that will typically get you past that maximum that takes you into outlier land. These special there's 1,000 different things that can occur, but for the most part, it's going to be very complex cases with multidisciplines. Like, let's say you have a case with like every discipline: nursing, physical therapy, occupational therapy, speech therapy, social worker, and CHHA. You're going to definitely exceed like 30-something visits, or whatever that is. Another example is you might have a very intensive therapy, like 3 times a week for whatever reason. 3 times a week therapy, that's probably going to exceed. If you have that with like nursing, now you're probably in excess of whatever that threshold range is. Another example is diabetic patients. So not the typical not typical, sorry, but not like the patient that's taking oral diabetic medication, but we're talking about like injection kind of patients. So when you have injections for diabetes that your agency is responsible for doing, you're probably out there once a day doing once a day diabetic injections, like insulin injections essentially, or twice a day, or sometimes in like really edge cases, you have a 3 times a day. So this is QD once a day, BID twice a day, and then TID thrice a day. So what are some examples of like why you would need to be there 3 times a day or 2 times a day or 1 time a day? The patient might need diabetic, insulin injections if, for example, let's say they live with family and they need injections twice a day, morning and evening or whatever, before meals or, whatever that is. And like, let's say in the evening, they have a caregiver, like they live with their family, the family's there, they can do it, they do it. But in the morning when they need the injection, everyone's out of the house. So now the home health agency is going to send a nurse to do the injection every day at like 9 a.m. or whatever, whatever the time is. In that case, you're going out once a day. Over 60 days, that's 60 visits. You have now exceeded that outlier threshold, minimum threshold that will start getting you paid like additionally per visit. The more visits you accrue, the more payment you get. Now, back in the day when we had those agencies that would be like, let's say, we are niching down to only do diabetic injection patients. That's it. That's all we accept. This is our specialty. This is our niche. Like, this is what we're doing. Well, back then, the average payment for home health, outside of like any extreme case, like extreme clinical need, I'm talking about like just like teachings or, medication, teachings on medications, disease process, like single episode cases, things like that, would get you about 2,200 to like 2,600 per episode. But if you had a daily injection with that, now you were at like 6,000-7,000 an episode. And if you had twice daily injections, you were at like 12,000 an episode. And if you had 3 times a day which was like crazy, unheard of, like it's very rare, you would have like 18,000 for the episode. So there were some agencies that would like really just niche down into diabetes only and just do injection only and stuff like that. At some point, Medicare caught like kind of wind of that. And for one reason or another, didn't like that process. And so they put a cap on outlier payments. Now there's this cap on outlier payments. So this is very important to understand and keep track of in your agency, or you will lose a ton of money. The cap on outlier payments is that the total of outlier payments per month cannot exceed 10% of the total billing per month. What does that mean? Let's say you were supposed to get, we're just going to go like big round numbers so it's easy to calculate, right? Let's say you were supposed to get 2,000 for the episode, like just clean 2,000, right? But you have like a bunch of visits, and now with the outlier payments, that comes up to 5,000 for the claim. The part that shouldn't be more than 10% of your total billing is the outlier payment, not the base payment. So it's whatever's paid past the base payment. So if your base payment was going to be 2,000, but you got 5,000 instead, now you have $3,000 of outlier payments. You need to have minimally $30,000 of billing to get paid that $3,000. That is very important to think about when you are accepting patients. Of course, you don't always know when you take a referral what's going to be needed in that referral. So agencies are highly encouraged to like monitor this and, just make sure for your finances. So what happens to those payments if you're not getting paid for them? Is it like cancel? No, it's not cancel. Essentially, it goes into some credit kind of like calculation. And when you do have space for that, you will get paid for this. So let's say this month you had, back to our example, 2,000 base payment, 3,000 outlier, right? Let's say you had only 28,000 of billing, not 30,000 of billing. That means you're going to get paid 2,800 of the outlier, and 200 will go into this like pending kind of state until you do have space to then receive that amount. What does this do? It creates a kind of backwards incentive for agencies to not just like accrue these diabetic injection patients or whatever, because the diabetic injection patients, they can go on forever. Typically people's condition, like when it comes to diabetes and things like that, they don't get better, right? Like they only get worse over time. Like maybe they'll stabilize for some time, but like over a decade, right? Like you're probably going to like increase your dose of insulin or just whatever, like it typically like progresses, the disease progresses. So once people take these diabetic injection patients, it's typically like really hard to discharge them because it's unlikely that they're going to get a non-working caregiver if they're like living, let's say like it's a patient living with the daughter and the daughter's family. In that original example, okay, no one can inject in the morning. They have to take their kids to school and then they go straight to work after. Like the morning injection would be like at 5 a.m. if they could do it, whatever. But they just can't make it happen. The patient wakes up at like 8 a.m. I don't know. And everyone's gone from the house. In the evening, yeah, they do the injection, no problem. In the morning, there's just no one available. There probably won't be anyone available unless you recruit a neighbor or something like that for like a long time, like forever, because that family is going to keep working, keep going to school, like whatever, whatever their family situation is. Or you have a patient who lives by themselves. Unless they acquire a roommate or, go to a facility or something like that, they're probably not going to find someone who can just reliably inject them every single day at like 7 a.m. and like 7 p.m. So once you get diabetic injection patients who are unable to do it themselves, it's hard to discharge them. So what this does is it's essentially limiting the number of diabetic injection patients that people are going to be able to take. If your outliers come from like a case mix of therapy and things like that, you're probably not going to exceed the outlier cap all day long because those therapy cases come and go and ultimately they rehabilitate and exit. So it's not this compounding build of outliers. With the diabetics, you are compound building outliers because they don't really leave, but sometimes they come. So that's really something to keep in mind because they're very expensive to maintain. Twice a day injections means you're paying the nurse twice a day to do the injection. So that's 2 visits. This is 120 visits an episode. The payment that you receive is appropriate for that amount because that's what it costs to maintain the patient. It's just really important to know this. I've seen a lot of agencies come to us and just be like, hey, we're not getting paid for these cases. And like, I don't know what's going on. We should be paid this much, but we're getting like $3,000, but we should be getting like 12,000, like this. Well, that's really unfortunate. You haven't lost that payment, but it is going to wait until you have space to receive that payment. So let's say now you're in this situation. What are your options? You either have to grow your non-outlier types of patient census, which is easier said than done. And if we could do that, we would, already have grown. Or you need to reduce the kinds of patients that create outliers until you have a good match. Or you need to understand that, hey, the growth is going to take some time and I'm going to self-fund this until I have the space. And then I will ultimately receive these payments at some point. So Typically, if you have questions like this, your biller is going to be the best person to ask. Of course, you can ask consultants, but they will need to have, like, we get a lot of calls. Do I have space for this patient? Meaning outlier type of space. To know that, I would have to be able to get like your last 3-4 months of exact numbers of billing and your projected amounts for this patient to make a calculation that will be more or less accurate. So that question is best asked to your biller. If you don't have some external biller that bills for a lot of people and you just have it internal, of course, call whoever you can, call your consultant, call whatever, but they will have to do like this extreme kind of calculation. Your biller will have those numbers already in place. So they will be able to like just give you that info much faster and easier than anybody external to your company could. So that is it for outlier payments and LUPAs. Two very, very critical billing kind of variations that you should be very aware of if you're going to run a home health agency or work in one. Please, please, please learn those rules to the best of your ability. It's really going to affect your money. So that's that. This was LUPAs and Outliers. Again, my name is Mariam Treystman for the Home Health Consultant. And if you like our content, please like, share, and subscribe. Thank you.